Hello.
Yes, you're audible.
Yeah. Ma'am, among the two, who will be the primary first speaker, ma'am?
We have a fairly informal setting, so it depends. Dr. Gauri, how do you want this to be done?
I think it'll be useful to see the cases first. Mine is just sort of a summary of what we would do from a genetic perspective. So I'd be very keen to listen to what Dr. Maniram has to say first.
Okay. And so initially, would Dr. Saravanan or Dr. Kalyan, would you mind just speaking a little bit and introducing the topic? Either of you?
Yeah, I mean, I'm happy, or Dr. Kalyan, whichever, whoever is. I mean, I'm happy to do it as well. So.
Sure, sir. Okay.
Yeah. Okay. Great. Okay. Thank you, and thanks for whoever has joined us today. It is a very, very interesting and important topic today that we are going to be discussing. This is an area where there is so much lack of clarity as much as there is clarity. And I, for one, am trying my head around to try and find out what is exactly the existing evidence. Unfortunately, there's very, very little research that has gone in. There's only one randomized controlled trial which has looked at cardiomyopathy in these children, where there is some evidence that ACE inhibitors and beta blockers can be helpful in these children. These are children with various neuromuscular disorders. They tend to have three important conditions, cardiac conditions: one, cardiomyopathy; two, arrhythmias; and three, conduction disturbances, in various permutations and combinations depending upon what is underlying genetic abnormality. And intricate knowledge of that is very, very important so that we can identify these problems early. Now that our respiratory colleagues are doing an excellent job in trying to keep these children alive with their respiratory problems, particularly with BiPAPs and all that kind of stuff that's coming in, and also spinal surgery, we are seeing a lot of cardiovascular mortality in these children. And I was just quickly looking at one article that was actually one presentation in the ESC in 2022 that I was aware of from Spain, where 25% of deaths in these children was sudden cardiac death. And that's an area that's completely unexplored in these children. So loads to understand, loads to know. And I'm sure Dr. Maniram is going to go through all of this. And Dr. Gauri Krishna will give us an insight into the genetics. And it'll be a very exciting session. Thanks for all of you who have joined here. And I'll hand over to Dr. Kalyan to see whatever he wants to add, and then the speakers can start. Thank you.
Yeah, thank you for invitation, ma'am. It was a very good platform, and I'm looking forward to have a good discussion. We have a lot many inherited metabolic problems who keep regularly coming for a cardiac evaluation at Geneva. Lot many cases, but unfortunately, because of somehow lack of time or lack of too much of interest on these subsets, we don't too much involved in the further management, because we have a pediatric team just besides Geneva and pediatric cancer is there at so yeah, but yeah, and I would definitely like to looking forward to see the research developing on this area. Dr. Maniram sir is a senior to us. He's practicing in Tanjavur. And over to you, sir.
Thank you, Anna, ma'am, and ORDI for this opportunity. This is indeed a novel experience for me as well. And I'm going to predominantly focus on Duchenne's muscular dystrophy, because that is the commonest disorder. And as I was discussing with Anne Matthew, ma'am, I think even with Duchenne's, there are a lot of challenges in what is optimal cardiac management. And as Saransa mentioned, like the neurologists and the respiratory doctors are doing an excellent job with managing the morbidities associated with these muscular disorders, which is why now the focus is shifted to cardiology. and what the cardiologists could contribute to improving outcomes in Duchenne's muscular dystrophy. So I will start with a rather provocative slide. Like, can you see my slides?
Yeah.
Yeah. So if I were to ask you, would you consider orthotopic heart transplant, cardiac transplant, as a realistic option in the management of a child with DMD? Would you think I'm completely mad? Or do you think I'm an over-optimistic idiot? Which of these two options would most of you think about? I think most of you would probably think I'm mad, isn't it? 10 years ago, when I was still a pediatric trainee, the same question, the ideal question would have been, would children with DMD survive to adulthood? And I think most of us, at least as a trainee, we thought DMD is not compatible with survival to adulthood. But today, with improvements in, especially with the introduction of corticosteroid therapy and with good respiratory care, I think a reasonable amount of people would actually survive till adulthood. And this was actually a paper which came a year back, which was actually a survey of 30 big pediatric cardiac units in the US and Canada. And the question was, would you consider a ventricular assist device, which is probably one of the most advanced non-transplant heart failure therapy available for children and adults with heart failure? And I was actually surprised to see that only 16% would not consider use of such an advanced therapy in children with muscular dystrophies. 84%, or I would say a vast majority, would actually consider such therapy. And this is something which most people would not even imagine a decade ago. So that speaks volumes of the amount of improvement which has come with the neurological and pulmonology management of this condition. So the question remains, to do or not to do? That is the question. So I often like to quote the Bard for difficult situations. And I think cardiac involvement in neuromuscular disorders is indeed a difficult situation, because for most of us who are not routinely involved with care of such patients, we tend to think that this is a bad disease and that the children are not going to do well. And we tend to minimize our impact on these children as much as possible. Now, generally, when you are a pediatric trainee, both neurology and genetics are considered to be rather dry and boring subjects. So we don't really concentrate much of them during a training period. But somehow I was always very interested in genetics. And I have this very interesting story about my first cardiac genetic case, which was a suspected channelopathy. This was way back in 2013 when I was a pediatric cardiac trainee. So we had a patient whom we thought had long QT3. And at that time, massive parallel sequencing was not available, I think, in most parts of the world, and it was definitely not available in India. So I actually wrote to the group in Germany who had first described the genetic change in long QT3, and they agreed to take up this case as a sort of a free case on a research basis. So we shipped the sample to Germany, and we waited for one whole year to get the report. And finally, when we did get the report was in German. And that was pre-Google Translate. It actually took us one whole month to get the report translated. I think times have changed now. I think we have wide access to genetic diagnosis, and it's available at a reasonable cost, probably among the cheapest in the world. And I think we should make good use of it, because this is not just about diagnosis. There are a lot more information which can come from genetic testing, especially with regards to prognosis and appropriate management. Now let's exercise the brain a bit. So this is just going to be a short detour into genetics for a couple of cases before we come back to neuromuscular diseases, which are our primary focus today. So this child was the third born of non-consanguineous marriage. The father was a South Indian and the mother was actually an Indonesian. He was fine. There was no significant perinatal issues. The family were living in Qatar, and at 3 years of age, he was evaluated for recurrent vomiting and plateau of weight gain. So they had thought of a metabolic condition and they done an extensive metabolic workup. The lactates were moderately elevated, but they could not pinpoint on a particular diagnosis. And because his development was fine, they sort of then left it like that, did not evaluate him further. He was kept on a metabolic cocktail for a few years, and even that was stopped, I think, at 5 or 6 years of age. From adolescence, he developed progressive ophthalmoplegia, and he also had significant activity restriction compared to his peers. So he was apparently playing football at a reasonably high level till 10 to 11 years of age, but subsequently he was not able to even attend practice properly because he was getting very tired. So he had an ophthalmic evaluation for the ophthalmoplegia, and the retinal examination showed this. So even for somebody who's not an ophthalmologist, I think we should be able to make out that the entire retina is black, and this is characteristic of pigmentary retinal dystrophy. The pediatrician also noticed that the heart rate was very low, and this was the ECG which was obtained at that stage. So you can see quite a lot of P waves. You can see a P wave here, 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 here. So there are quite a lot of P waves, but there are not enough QRS complexes. So you have a low heart rate and you have more P's than QRS complexes. That means that there is complete heart block. So what do you think is the diagnosis? So whenever you have this combination of external ophthalmoplegia, pigmentary retinal dystrophy or retinitis pigmentosa, and conduction abnormalities in the heart, the diagnosis is a condition called Kearns-Sayre syndrome. So this was again one of my initial cases when I was still a trainee. And this, as we all know, is a mitochondrial disease, which sort of explains the elevated lactates which were diagnosed at 3 years of age, even though he was asymptomatic from this perspective. So again, with great difficulty, we organized for mitochondrial sequencing at a research facility. And we also put him on a pacemaker. So as soon as we put him on a pacemaker, his symptoms improved dramatically as far as activity restriction was concerned. And he was able to you go back to play, and he was able to go back to most of his normal activities. So when we got the genetic testing, there was a novel large mitochondrial DNA deletion, which was consistent with a clinical diagnosis of Kearns-Sayre syndrome. Now, at that point, I thought that we had comprehensively managed this child's cardiac condition and that he was no longer at a risk for anything as far as the cardiac perspective was considered. But unfortunately, I was shocked to hear when the mother got back to me nearly 2 years later, saying that this boy had died suddenly at home. So apparently he was studying at home for an exam. Both the parents had gone out, and when they came back, they noticed that he was slouched against the table. And when they tried to wake him up, they realized that he had actually died. And only after that, when I did a detailed literature search, I realized that a small subset of these children with Kearns-Sayre syndrome, they might have more malignant cardiac abnormalities than just heart block. Some of them might have ventricular arrhythmias, which can predispose to sudden death, something which a pacemaker alone would not be adequate to prevent. So subsequently, all patients with Kearns-Sayre syndrome, I monitor them much more closely and look for any ventricular arrhythmias. And I actually had to upgrade a pacemaker to an ICD in one patient, only because I was looking out for small changes on a continuous basis. Unfortunately, this was not something which helped the index patient, but this was something which only the death of a patient taught me. And whenever you have Kearns-Sayre syndrome, it is not just AV block alone, which is the most commonly described cardiac problem in literature. A very small subset can have more malignant conditions as well, and we need to monitor very closely for them. No, I think that case sort of tells us, it's not just enough to, suspecting a genetic condition is not just about diagnosis. It is important to manage the child or the adult comprehensively and ensure that we do not miss certain associated conditions. Now, we had another family who was referred to us a few years ago for preconception counseling. They were a second-degree consanguineous couple, and the first child had died at 10 months of age. The child had developmental delay and recurrent infections, and pediatric neurologist had seen the child and asked for an echocardiogram, which was seen by an adult cardiologist and reported as hypertrophic cardiomyopathy. So the child had unfortunately died, and the family came to us a year after the child had died. So they had some images from the echo report, and looking at this pattern of cardiac involvement, so both the septum as well as the free wall of the ventricle was significantly hypertrophied. And looking at this pattern in a young infant, the only differential diagnosis I could think of was Pompey's disease. Its ECG was also consistent with Pompey's disease. There was a short PR interval and really high voltage QRS complexes in the chest. So I knew that this child had Pompey's disease. I knew that there was a 25% recurrence risk in subsequent pregnancies. But unfortunately, because genetic testing was not done, there was no way we could offer prenatal testing for this family, because the hypertrophy in Pompey's disease almost never occurs in the fetal life. It only occurs probably in the late third trimester or in the neonatal or early infancy period. So how could you ensure that subsequent pregnancies do not have the disease? It is possible only if a genotype had been established in the first case, which was unfortunately not done. So we asked them if they had any samples, blood samples by any chance, or any body fluid samples, body samples. It is a practice in this part of the world that the parents preserve the umbilical cord. So they put it in a small, chain, and they actually tie it around the child's hip. And when the child outgrows that hip chain, they sort of take it and keep it, safely. Now, this family had actually preserved the umbilical cord remnants in their, prayer room at their house. And the mother mentioned that she had it. So we asked her to bring it. The umbilical cord was nearly 2 years old at that time, and it had become very dried and shriveled. So we decided to see if we could isolate DNA from that. Now, this is not as simple as what we see in forensic, forensic shows, because there it is only identity. You don't need to have good quality DNA of the entire genomic sequence. But here we needed good quality DNA throughout the sequence. So most labs actually refused outright to do it. Finally, one lab agreed after after a lot of counseling of the parents saying that they may not be able to isolate the DNA. Thankfully, we were able to isolate good quality DNA in this particular case. And when we did genetic testing, we were able to identify a homozygous likely pathogenic variant in the GAA gene consistent with a clinical suspicion of Pompey's disease. So this was the very first reported case of DNA isolation from dried umbilical cord. And we had actually published this in the American Journal of Medical Genetics. But as we all know, the proof of the pudding lies in the eating. So we had to help the family, and we encouraged them to plan the next pregnancy. The mother conceived naturally with twins. that actually doubled our problem because we had to do amniocentesis of both the twins. Thankfully, both of them were only carriers for the disease. The mother delivered healthy twins at term. So this was the twins at 10 months of age. They are subsequently now nearly 3 years old and doing very well. So with that, we'll come to the topic proper, which is, cardiovascular involvement in neuromuscular disease. For those of you who are interested, there is American Heart Association guidelines, which was actually published way back in 2017, which offers a really comprehensive summary of the evidence which was available till that stage on this difficult subset. Now, the two most common group of disorders with cardiovascular involvement are, of course, muscular dystrophies, which are Duchenne's and Emery-Dreifuss, and also the big group of disorders which are clubbed together as limb-girdle muscular dystrophies. Now, most commonly, these present with cardiomyopathies. There are some forms of diseases, especially Emery-Dreifuss and some of the limb-girdle dystrophies, which do not present with cardiac involvement, but a vast majority of them present with cardiac involvement, and that is almost always in the form of a cardiomyopathy, a dilated cardiomyopathy. Arrhythmias are, yes, they're common, but they're often a late feature of sort of burnt out diseases. So the early feature is only a dilated cardiomyopathy phenotype, and conduction abnormalities are usually rare except in laminopathies and in Emery-Dreifuss muscular dystrophy. So the laminopathies, actually laminin A and laminin C, I think the commonest presentation I have seen is as heart block rather than a primary muscle problem. And only on evaluation for the heart block did we end up, heart block and DCM did we end up identifying the laminopathies. Because at least in the early stage, the muscle weakness is fairly subtle. And again, laminopathies, at least in my experience, I picked them up only in the adolescent or the young adult subset. Although from what I can see in literature, it can occur in early childhood as well. There are also a large group of disorders, other disorders, which can have cardiac involvement. I like to point out Friedreich ataxia. Friedreich ataxia is something which we have seen very commonly in our practice. It might be because I worked for a long time in a referral institute for hypertrophic cardiomyopathy, and we accumulated quite a large series of hypertrophic cardiomyopathy, both in adults and in children. And a substantial subset of them ended up having Friedreich's ataxia. So this is probably reasonably common in our population. The other disorder which I've seen, again, reasonably commonly is central fiber type dysproportion. This is, at least the autosomal recessive form, is a very bad disease. Children present at a very young age with very severe forms of cardiomyopathy, and the response to treatment, at least in my experience, has been very poor. So as a cardiologist or a cardiac trainee, and I'm sure most cardiologists here would agree, the cool kid was interventions. And heart failure, and especially neuromuscular disorders, was the boring thing which all of us try to avoid or try to push on our juniors. So I was also something on a similar, that was my outlook as well. I was actually forced to do the neuromuscular clinic for a full year as a trainee because I had expressed an interest to learn speckle tracking echocardiography. So, and because nobody agreed to do the neuromuscular clinic, my boss made a deal with me that he will teach me speckle tracking if I agreed to do the neuromuscular clinic for a whole year. And so I had to, I initially took it up as something which was a punishment for me, but that was something I actually enjoyed throughout my training. We did this clinic one day every fortnight or sometimes one day every month. And I personally learned quite a lot from those clinics, and that was something which I've been able to carry forward to my practice as well. So we'll go to some case scenarios. All of them are Duchenne's muscular dystrophy, except for one. The first was a 10-year-old boy diagnosed to have Duchenne's after an elder sibling had the diagnosis. At that point of time when I saw him, he was still ambulant and he was on corticosteroids. There was no dyspnea on exertion or lower respiratory infection of significant importance. And he was referred for his first cardiac evaluation. So this was his echocardiogram from the apical four-chamber view. So you can make out that the heart is really squeezing really nicely. And when we did a detailed evaluation, the ejection fraction was actually supranormal, it was 73%. We also did speckle tracking echocardiography. The GLS, which is the composite value, was above the normal limits. And when we looked at regional contraction by what is known as the bullseye, it was completely normal. So just for the neurologists here, the bullseye has to look bright red. If it's pale red, that means that part is not contracting very well. And if it's blue, that means things are really bad. So here it is all bright red, and the ejection fraction was completely normal as well. So what will you do next? Would you say things are fine, ask them to come back after a year, or would you intervene? Would you consider anything, doing anything here at this point of time?
Yeah, I think we'll serially monitor for the contractility in the future, probably 6 months follow-ups.
So actually, there is, it's not a large amount of data, but there is some data to suggest that even if the LV function is completely normal, around the time when they reach the second decade of life, which you can say is 10 years of age, you should probably consider starting them on some kind of heart failure therapy. So this is again from the same survey which I had presented some data on initially. So when they surveyed the use of AC inhibitors, more than 2/3 would actually start AC inhibitors at the age of 10, even if there is no ventricular dysfunction. While less than 1/3 would consider it only if they see some kind of ventricular dysfunction. With regards to the other two commonly used drugs, beta blockers were always started only if there was some kind of ventricular dysfunction, not prophylactically, as was aldosterone antagonists. Although a small percentage said they would consider starting aldosterone antagonists at age 10, irrespective of ventricular function. So this has actually made its way into recommendations as well, that at age 10, you should probably give consideration towards starting AC inhibitors in these children, irrespective of the ventricular function. Now, the next is actually something which is seen very commonly in my practice at least. This was a 12-year-old boy who was diagnosed to have Duchenne's muscular dystrophy in early childhood. He was on regular follow-up with a pediatric neurologist in Chennai, and he was actually on prednisone, which the family were actually getting from overseas. I'm not sure about it, but what I was told was that prednisone is superior to prednisolone in these neuromuscular disorders, and which is why they were specially organizing it from overseas and giving the child that. Now, so I mentioned this just to give you an idea on how committed the family were to this child, and that they were giving the child the very best of care available. He was on yearly echocardiograms, and the last echocardiogram had shown mild LV dysfunction. So this boy, I think, was somewhere around 35 to 40 kilos in weight. And he was started on NVAS at a dose of 2.5 milligram BD a year back, and was on the same dose since then. Now, just to give you a perspective, this is the sort of dose which I want to achieve on a 6-month-old child with dilated cardiomyopathy who probably weighs around 7 to 8 kilos. And this was the dose which was being used for a 12-year-old child with ventricular dysfunction. So they had actually visited family in my hometown, and he had become sick with a respiratory infection needing hospitalization, which was why he was referred to me. So this was the echocardiogram. So this was the apical four-chamber view. yes, there was some dilatation of the heart, and probably looking at this view, I would agree that there was probably some mild ventricular dysfunction, which was the assessment by the cardiologist who had seen a year back. But when I did other views, so this was an apical 2-chamber view, the ventricular function was not as robust as what it was in the apical 4-chamber view. So when I did a more comprehensive LV function assessment, on the 4-chamber view, there was probably only mild dysfunction, but on the 2-chamber view, it was probably moderate to severe. And when I did a composite biplane EF, there was, at least moderate LV dysfunction, which was more than what I would have thought of personally looking at the 4-chamber view. So this again goes to highlight that you should not look at only one parameter to assess the ventricular function in these kids. And when we did speckle tracking, the speckle was actually very, very low. And so I mentioned, you should see bright red. Here it was predominantly pale red and areas which are nearly white. So there was significant ventricular dysfunction, even though the EF was not adequately conveying this. So this is just to highlight, things can progress very rapidly. So you need to keep very close eye on these children when they start developing ventricular dysfunction. And you also need to manage this heart failure very aggressively. So this particular family, when I presented a picture which was different from what had been reported to them, they were not willing to, undergo further treatment here. They wanted to go back to their regular doctor. So I don't know exactly what happened subsequently. But, if you ask all cardiologists, they'll tell you 2 words which are very, which are probably the it words in management of heart failure, which are what we call the 4-pillar approach and something called GDMT or guideline directed medical therapy. So the 4-pillar approach is using 4 groups of drugs. So the AC inhibitors, the beta blockers, aldosterone antagonists, or your spironolactone, and a group of drugs called SGLT2 inhibitors. The flagship drug of the group is dapagliflozin, which is probably the most commonly used drug. So this is actually a drug which was developed as an oral hypoglycemic agent and was subsequently and by chance noted to have a significant benefits in improving cardiac function. Nobody really understands how this drug works, but we do know that it works. Now, there is good literature for the use of these drugs in adults with LV dysfunction. Most of them probably have ischemic LV dysfunction. But there is not adequate data in other subgroups. There is no adequate data in pediatric LV dysfunction as well, but we have sort of imbibed these guidelines in treating children with dilated cardiomyopathies due to other causes. And there's absolutely no reason to believe that this would not work in this subset of neuromuscular disorders as well. I'll highlight this with a case as well. So this was a 20-year-old who was diagnosed to have sarcoglycanopathy. Apparently, it was genotype positive. Now, sarcoglycanopathy is one of the limb muscular dystrophies, and these can be associated with cardiomyopathies. The report was not available with the parents, but the doctor's notes clearly mentioned genotype positive sarcoglycanopathy. So he had genetic testing, but probably the parents missed the report. Again, he was diagnosed only after his elder sibling died. He presented to me in August 2022 with functional class 3 symptoms. He was nearly bedridden. He was only taking care of his own needs, and he was not even venturing out of the house. His NT-proBNP at that time was very high. And on a 6-minute walk test, he stopped at 5 minutes because of dyspnea. And he was able to cover less than 300 meters. If I remember right, I think it was around 210 meters. He had been noted to have mild LV dysfunction a year previously, and again, he was on a very suboptimal dose of enalapril. So this was his echocardiogram when he first came to me. So you can see that the ventricle is not really contracting very well. and there was severe LV dysfunction with an ejection fraction of only 16%. And when we looked at GLS, you can see there's hardly any bright red here. It's either white or even some blue popping in, which means that things are very, very bad. So what I did was I tried to optimize this therapy as well as I could. So when so I increased his dose of NVAS, and after sometimes switched him over to a group of drugs called ORDI. There's not enough evidence to speak, for the recommendations to include ARNIs over AC inhibitors. But I think anecdotally, there's some data to suggest they might be better in this subgroup of drugs as well. So I also introduced a second as well as third agent here. The second agent was started at a reasonable dose, and the third agent was initially started at a low dose and subsequently increased. Within 3 months, I could start seeing changes. So his heart rate had actually come down to 100, and I was able to further optimize this group of drugs and add the fourth agent as well. By a year after his initial presentation, he had improved remarkably to functional class 2, and I was able to start coming down on his diuretic therapy because he wasn't as congested as he was previously. And by January this year, he was on a very low dose of pure diuretics and really good dose of all the heart failure medications. And this was his most recent echocardiogram. Now, the ejection fraction had only improved marginally. So from 16%, it had become close to 30%. And there was some improvement in the GLS as well, with some more red popping in, but not much. But functionally, there was a significant improvement. So his NT-proBNP, which was 9,000 to start with, even though it had not normalized, had come down to 1,500. He was able to walk the entire 6 minutes, which he was not previously able to. And from 220 meters, he had more than doubled and was walking to 470 meters. And his dyspnea on walking had come down significantly. Now, at that time, he was arguing with me and his mother that he needed to go to a job because he was fed up of being at home. And he actually offered to be, because he used to love driving before he fell very sick, he offered to take up the driver job with me. So I actually had to convince him that my hours were very bad, that I was probably not the right employer for him. But that was the amount of improvement which I was able to see within probably a year and a half of adequate management with drugs. So while on the topic of GLS and speckle tracking echocardiography, one other modality which we could use to pick up cardiac changes early is cardiac MRI. And very specifically, we look for something called late gadolinium enhancement, which indicates that some degree of fibrosis is happening and that area is less likely to contract well. So even though it's just an anecdotal single case, I think this might sort of convince you, or at least make you think that guideline-directed medical therapy could potentially work in neuromuscular diseases as well. So what do the guidelines currently say about appropriate management in Duchenne's muscular dystrophy? I think cardiac evaluation at baseline and at least annually from 10 years is definitely recommended. There is, even though it's at present a class 2A indication, a recommendation, I think AC inhibitors or angiotensin receptor blockers should be considered at 10 years of age, even if the LV function is normal, because it's only going to be a matter of time before LV dysfunction sets in. With beta blockers, prophylactic therapy is definitely not recommended based on current evidence. But if you see mild or more LV dysfunction, you need to get them on beta blockers. And aldosterone antagonists, probably only when there is mild LV systolic dysfunction, or if you're following them with regular cardiac MRIs, which is, I don't think any unit in our country is doing. If you see LGE, maybe that is one point where even if the function is normal, you should consider starting these drugs. With respect to the other drugs, ARNIs and SGLT2 inhibitors, there is no data available as of now, although anecdotally it has been used in this population. Now, this is my last case scenario, and it's a hypothetical scenario as well. This is a 39-year-old mother of 2 DMD children who's under your follow-up, one of your pediatric neurologists, comes to a routine clinic visit for the children, and at that time, because she knows you very well, she complains that she has been having dyspnea and exertion over the last 1 year. Now, this is a mother who probably complains to you during every visit for something or the other because she's managing 2 children with really bad diseases, which takes away a lot of her time. So it is not unusual that we will dismiss this as, as non-function, non-organic, and probably, prescribe a placebo as well. But is that what you would do? Would you do anything differently in your practice?
Can I ask Dr. Saravanan to answer the question? Because we do it differently. We don't follow.
And I didn't want to interrupt a very, very nice presentation going in. So yeah, we have a very low threshold.
To answer your question even in the beginning, because we don't do these things. The 2017 guidelines, we follow the 2018 guidelines, which have changed.
Just a quick recap. We'll discuss those things. But in this situation, it's very, very important for everyone attending to know and understand that women who are confirmed to be carriers of DMD at around that age, around 40, tend to develop a degree of LV dysfunction due to the DMD itself. They will not, or most likely, are not likely to develop any muscular dystrophy, but cardiomyopathy is quite common in these women. Roughly, it says that it's around 1 in 20 women can develop that. Therefore, you need to look out for that. So you will most certainly not discount that symptom and investigate her.
Thank you, sir. This, as sir pointed out, it's surprisingly very common for the carriers of dystrophin deletions, which are the mothers of children with DMD, to have cardiomyopathies, especially in the 3rd or 4th decade of life. And this is actually a class 1 recommendation, even though the evidence is not very strong. This is actually a class 1 recommendation that you start screening them from around the 3rd decade of life. So it's important, to take care of the parents as well, in addition to the children. So I hope I'm not reached this stage yet with the audience. And, with that, I'll come to the end of my presentation. I've mentioned my email ID and phone number if any of you want, further information. And with that, I'll stop sharing as well. And I'm happy to hear what Saravanan sir and Kalyan Reddy has to add to this.
That is a very, very nice presentation, Dr. Maniram. I wasn't honestly expecting that. It's a beautiful presentation, and I'm really impressed with the work that you're doing. I just wanted to make a couple of observations before people ask questions. And are we going with questions, or are we finishing the talk, both the talks, and then taking questions? I don't know if Anne is.
I think it might be useful to take questions, Dr. Saravanan, because this is cardiology and completely different.
Dr. Saravanan, you and Dr. Kalyan Reddy are the moderators. You'll decide.
Yeah.
Oh, great. Okay. Well, I think it's a good idea. I agree with Dr. Gauri that it is good that we take the clinical questions first and then go on. I will start the discussion. I'm very impressed with the fact that you have given some survey of how people look at this, because there is so much nihilism about these children thinking they are bound to die. And so putting ICDs and transplants in these children considered to be an absolute no-no. And I'm so glad that you showed that 75% of us, sensible people dealing with these children, would agree that we should go all out and do everything for these children. It was also interesting to observe that more people will go for VAD than for transplant. I think it's for obvious reasons that the transplant involves a lot of immunosuppressive therapy in these children. They are prone for infections, etc., etc. So it's probably a pragmatic choice that you would go for VAD rather than for transplant, which is also a very interesting observation. The patient with KSS that you mentioned, a couple of things I wanted to observe. Your ECG showed there was apacing, and sinus node disease is unusual in KSS children. It's usually AV node disease. So probably that child had fairly extensive conduction tissue disease. Also, a frequent device check. It's a very simple thing. A frequent device check would have given any evidence of short runs of NSVT as high V rates, and that could have prompted an upgrade to a defibrillator, which would have avoided a very complicated situation. I would like to know your thoughts on that, where they lost the child. So whether a more intense device interrogations would have avoided the situation where one could have upgraded to an ICD. And on a general note, these children are now living longer, and therefore things are coming to light that we previously did not know. And I mentioned when I did the introduction that 25%, it's a very small subset in a Spanish study, 64 children, 24% of death was due to sudden cardiac death. So are we now, if we are going to go ahead and put a device in, should we not straight away go for a defibrillator anyway in these children rather than put a pacemaker in? Because the device-related complication is going to be very similar, except for cost reasons, whether it is a defibrillator or a pacemaker. So a couple of observations that I made that I would like your opinion on, Dr. Paediatric.
Sir, with regards to the KSS patient, actually that was a magnet ECG, which is why the atrium was placed at 100.
Oh, okay, fair enough. Okay.
He had only heart block when you put the pacemaker in.
Okay.
And again, like I thought at that time, I thought, and my bosses thought as well, that, it's only heart block. So we put in a pacemaker, he's not anymore at risk of sudden death. And only when he died did we went and we did an extensive literature search, and we realized a small subset of them developed ventricular arrhythmias on follow-up. Subsequently, we've been much more careful with KSS. Like we have 4 or 5 patients in our follow-up, and one of those patients actually had non-sustained VT on follow-up, which we immediately, subsequently all our KSS patients are on remote monitoring because
Good.
they are.
That's another thing I wanted to mention. Yes,
yeah.
Great. Yeah.
So one of those patients we upgraded to an ICD because we saw some non-sustained VTs. He has not had a shock since we upgraded. I think it was 2 or 3 years since we upgraded. But that was an eye-opener, and I did not know this could happen till that child died, unfortunately.
Excellent, great. And on a general note, I do a lot of Holter monitoring. Some of my patients get a bit irate, patients' families get a bit irate that it's expensive. But I do a lot of Holter monitoring on these children because, what is in the literature is what we know. And there is a lot that we do not know about these children. And so the fact that they have a normal ECG on the day when you're seeing does not mean that they wouldn't have any either arrhythmia or conduction tissue disease. So any NMD child, I have a very low threshold for doing Holter monitoring.
And just one note about the mothers with DMDs, because as I mentioned at the start, my wife's a fetal medicine specialist, and we do a lot of, she does a lot of genetic work. So she gets a lot of mothers who come for prenatal diagnosis, if a previous child has a muscular dystrophy. And so you mentioned 5%. I think roughly we have seen, like we do echocardiogram screening of all the mothers when they come for their prenatal evaluation. And I think we have close to 10 families with Duchenne's at the moment in Tanjavur. And one of the mothers actually had mild LV dysfunction. She was completely asymptomatic. She was in her early 30s. So that sort of goes with the number that you had quoted as well. So, yeah. Even though it's from a very small subset.
We really need to be very careful with these women, and they are bound to develop the disease. And so again, they might say, "Oh, I'm feeling so well. Why are we doing all these tests?" So it's very important to educate them and then do that. And we endeavor a lot trying to do that very recently, and very kindly referred a patient who actually was diagnosed to have postpartum cardiomyopathy. She is 33 now, and 7 years ago when she had the child who is DMD. 5 months after her delivery, she developed LV dysfunction, and they called it postpartum cardiomyopathy and left her like that. And now when we assessed, and then we saw that we were going through the whole. Fortunately for her, she's actually well now. but we were very intense in trying to find out what is actually the case, the underlying situation there. So these women, we normally do an annual, if it's completely normal, we do an annual echo with GLS. And you did a very nice exhibition of GLS and the spectral tracking technique, which for the non-cardiologist here is very important to understand. It's a very, very useful technique to identify early cardiomyopathy. Any other questions and any comments from anyone else? We could just. Dr. Maniram did a very good job, and I was so impressed with the data that you have collected. And you're in Tanjavur, right? Okay.
Yes, sir.
It's just, we're all widespread everywhere. It makes it difficult for patients and families to find us and get treatment. I was talking to Anne saying that at least in Bangalore, we need to try and put all of us together in one place so that it's easier for patients. And it'd be lovely to have someone like you in Bangalore would be fantastic for us. So it's just one of those things. And it's difficult for patients to travel all over the country to see various specialists. And but at the same time, I know one could argue that there is a need in those areas where it is not much facilities available, and someone like you doing a fantastic job there. This is very, very much appreciated. I'm really impressed.
Actually, I would say destiny is what brought us to Tanjavur, sir. Like, both of us thought Tanjavur is my hometown. Both of us thought we'll be somewhere else. But we ended up in Tanjavur, and we set up Tiny Hearts, which is our unit here for 4 years. And yeah.
It's a lovely town that, I mean, I'm one of my relative, my very close relative lives there. It's a lovely town, Tanjavur. I love it. I like the place very much. But
yeah.
Affordability is a concern, isn't it?
Very much, sir. Very much, sir. It's a big, huge, especially with genetics, we have a substantial amount of genetic heart diseases here, including channelopathies and cardiomyopathies. And like even for the proband, testing for the proband, there are a lot of economical as well as social challenges. And the subsequent, screening of the family, cascade testing, it's near impossible as of now. Hopefully things will change, sir, but at the moment it's very challenging.
Sure. We could have this conversation in the next.
Yeah, we should probably have it offline, sir. Just to
offline. Yeah, we should discuss it. Yes, but any other questions from anyone else who's attending? Please feel free to unmute yourself and ask Dr. Maniram. We have an expert here who's doing a fantastic job in a tier 2 city, tier 3 city, you could call it. I know the city very well, and I know that temple. I've been to that temple a lot of times. It's a beautiful city, but a very, very small city with very little happening there, and people have very little affordability generally, but they're very happy though. So money doesn't always buy happiness. And do you want to add anything to the? Yes, sir. Go ahead, please.
Yeah, well, sir, I had heard this topic earlier also, but yeah, it's an excellent presentation. Very nice presentation. Very lot of new things to learn. Can we move ahead with the next presenter?
Yeah, please. Yeah.
Yeah. Okay. Yeah. Over to you,
man. So I'll try and keep it as brief as possible. So disclaimer, initially this talk was geared towards inherited metabolic disorders and cardiomyopathy. So I just sort of tweaked it a bit to try and focus more on the genetics and neuromuscular aspect. And to be fair, this isn't my area of interest. A lot of it was IMD associated with cardiomyopathies. But I thought it would be a good opportunity for me to also refresh and learn again. I don't know if you can see my slides. Let me just go to presentation mode. And I might stop my video because my son's doing something and it'll be distracting, or I might not get the bandwidth. Right. So this is a very brief summary of the genetic spectrum, and I wanted to also very briefly touch upon new emerging treatments and just look at what neuromuscular phenotype along with cardiac presentation looks like for people who don't.
It's not moving.
I haven't gone ahead. I'm still talking. Go ahead. It's not going ahead. Yeah. Okay, now? Yeah. Is it going ahead?
Yeah.
So cardiomyopathy is
Yes.
defined as a disease of the myocardium associated with cardiac dysfunction. And Dr. Mani has done an excellent talk about how we have to look at cardiomyopathy in terms of presentation and treatment. So I won't dwell on it too much, just a brief introduction. So they're a very heterogeneous group of cardiac disorders, both with structural and functional abnormalities. And these are often of genetic origin. And interestingly, the first cardiomyopathy-associated mutation became possible only due to the previous research on origins of neuromuscular disorders. So the neuromuscular disorders pretty much fed into where we are in terms of the cardiac genetics. So neuromuscular disorders are known to be associated with cardiac disease, but the cardiovascular symptoms can be difficult to unravel due to low physical activity in this patient group, and thereby there's a lower strain on the heart, so to speak. But conditions like arrhythmogenic disease, they're often the first sign of a neuromuscular disease. So it can be a combination of both of them. So 25% of these, so now we have over 40 genes of associated with different types of cardiomyopathies, and 25% also cause neuromuscular diseases as allelic forms. So the main idea of this talk was to try and just touch upon sort of symptoms which are included in, dystrophinopathies, laminopathies, myotonic dystrophy, just a lot of these names which may be bandied about. But I think the main takeaway should be that the cardiomyopathies are a heterogeneous group of disorders, and the fact that the neuromuscular disorders or neuromuscular symptoms may come before or after depends on which part of the heart is involved, so to speak, in terms of genetic predilection. So I think it's just very useful to touch upon this topic while we're looking at cardiomyopathies associated with neuromuscular disorders. So the common involvement of heart muscle was the dilated cardiomyopathy in X-linked muscular dystrophy. And historically, that's where we were able to get a lot of the cardiac genetic work. And there are some excellent reviews which look at the history of cardiomyopathy genetics and how dystrophin was pretty much the godfather or godmother of this particular branch of genetics. So we also looked at the reason we have this very close association is because of the concomitant expression of gene products, both in the skeletal and the cardiac muscles, and sometimes even in the smooth muscles. And obviously, this is all associated with the proteins that we see associated with the myocytes. So there are different examples of neuromuscular disorders with the cardiac presentation. And I thought it'd be just useful to look at how the structure is to go forward in terms of what we are looking for when we classify them into different types of cardiomyopathies. So obviously you have the structural bits, and you've got things that talk to each other, so connectors, and then you also have something that helps with cytoskeletal integrity. So there's the myocytes, the cytoskeletal integrity, as well as signaling molecules. So all of these together, any problem with genetics of any of these can give rise to problems from a neuromuscular perspective, as seen with cardiomyopathy. So very briefly, I think Dr. Mani's mentioned quite a lot of these. So predominantly, we're looking at dystrophinopathies, the Emery-Dreifuss that he's discussed already. And of course, we can't forget the DMD, BMD phenotypes, as well as the limb girdle phenotype. So these all sort of fall under the various category of genetics. So they have all been defined. There are proteins associated with it, and the exact chromosomal location has also been defined in these particular subsets. So my initial talk was predominantly on these things, which are your Pompe Danon folks, because we're looking at glycogen storage disorders, carnitine problems, so with your fatty acid oxidation defects, as well as respiratory chain disorders. So predominantly my talk was around this because early diagnosis of these conditions means that we treat them, and some of it is dietetic. So very often the presentation is very neuromuscular, and the cardiac phenotype may or may not be picked up early in these, apart from conditions where you have problems with rhythm, which could be your, either primary carnitine or CPT2, and sometimes the respiratory chain disorders. Otherwise, some of these, especially, are not picked up early, apart from the Pompe. Pompe usually presents, especially in the pediatric age group, presents quite catastrophically from a cardiac perspective as well. So I think in terms of what is the association of cardiomyopathies with these particular neuromuscular disorders, so it ranges anywhere between 12 to 90% in terms of what you would see as an association of cardiomyopathies. And the most important one is Barth syndrome, where we see high rates of fatality in boys along with neutropenia when they present with significant cardiac failure. So that's the sort of the range in terms of association of neuromuscular conditions with cardiomyopathies. So as I said before, you have very specific, so they can be non-specific in terms of how they present, and for us to be looking at genetic and neuromuscular phenotypes. I think the most important thing is that, if you found an AV block, it's usually maybe associated with myotonic dystrophy. So these are just the very few things that may indicate that this might be a specific genetic disorder. So if you have atrial fibrillation and laminopathies, so when you're asking for genetics, to also remember to ask for the mitochondrial panel. And of course, if you have a complete AV block, which is often a frequent cardiac feature of Emery-Dreifuss dystrophy. So I think just to keep in mind that it's very non-specific, but we do know that certain specific associations may set some alarm bells ringing, and we should be ordering the right genetic panel as well in order to try and get to the diagnosis. Obviously, in India, the whole exome sequencing is a lot more present and available, and costing, of course, is an issue. But we used to prefer panels when I was practicing in the UK. So that's the reason I'm talking so much about the panels. But of course, with the whole exome sequencing, if you think it's mitochondrial, it's important to add that panel as well. So very this is sort of preaching to the choir, so I'm sure all of you know this, but I think the most important things I wanted to talk about were, if you're thinking about the major contractile proteins, you have these two groups, of hypertrophic and restrictive. If you're talking about things providing strength to the myocardium, so it's an easy way to remember, and are involved in signaling between neighboring cells. Then you're talking about rhythmogenic with all of these different proteins that are associated with the myocyte. And finally, you've got the dilated, where you're also looking at maintenance of the cytoskeletal integrity, where the Z bands linked to the plasma membrane. So based on that, you're also thinking, so if you looked at dilated, so if it's predominantly dilated, should you be thinking about genes that are associated with the cytoskeletal integrity? Or if you think it's restrictive, you're still thinking about the sarcomere, the actin, and the actin myosin. And hypertrophic is the same sort of phenomenon. And if you're looking at arrhythmogenic, you have another set of proteins that you would be worried about. So that sort of gives you an idea as to what genes or what proteins you're looking at that might be involved with these cardiomyopathies. So again, this comes under the remit of the cardiologist, but just for us to remember when we're seeing patients in clinic, that we make sure that if this is what we're looking at and we're worried about a cardiac involvement with neuromuscular disorder, that we definitely have a plan in place and have a good cardiologist. And obviously tonight we've had the opportunity to interact with a few of them, so that we are able to refer on and know what to look out for and immediately escalate it, so that we can work well with our colleagues. But from a genetic perspective, so if you've seen a child with cardiomyopathy under the age of 10, or there's neuromuscular symptoms and you're worried there's cardiomyopathy, obviously you do a 3-gen family tree, making a special note of congenital heart diseases or sudden infant deaths. See if there's any X-linked or mitochondrial inheritance, look for consanguinity, rule out pregnancy. If the mother's pregnant, again, in terms of trying to get a more speedy action, look at diabetes, medication infections, polyhydramnios, see if there's birth asphyxia, because that can also cause transient enlargement of the heart, valvular heart defects associated, and if they look syndromic, so that's another important thing. If there are significant muscle weakness, so that helps us narrow things down, and if there's developmental delay, and if there's especially fluctuation in level of consciousness, with intercurrent infections. So you're thinking more metabolic, or if there are regression syndromes along with other special senses problems like deafness or visual problems. So this would be like a brief summary of what you would think about when you're seeing a child under 10 with neuromuscular or a cardiac phenotype. So very briefly about X-linked DCNP, because I thought it'd be just useful just to look at this, because we've had discussions. So they're caused by mutations in the dystrophin gene. And as I said, this was sort of the godmother or godfather of us finding the other genes associated with cardiomyopathies once we got to know about dystrophin. And I think what it does help is, they demonstrate a sort of common pathogenesis constructing the basis of both the cardiomyopathies and neuromuscular disorders. And this was really critical in our understanding of the evolution of cardiac genetics. So dystrophin mutations described now usually cluster either at the N-terminal part of the gene or its mid-root domain. And these two different localization sort of really govern the variance in the mechanism and clinical picture of disease. So that's really important to understand. So in the former case, so in the N-terminal part of the gene, when it's located, it's usually part of deletions or insertions, which involves the muscle promoter of the dystrophin gene, abolishing expression in cardiac and skeletal muscle. But in skeletal muscle, and this is not in cardiac muscle, this is sort of partially compensated by the expression from the other promoters. And therefore, in this type of mutation, the dystrophin expression in heart muscle is almost absent, while keeping traces of protein in skeletal muscles. And that's why you can see this very variable progression of cardiac phenotype in the neuromuscular. So there is a dissociation. And this is really important to understand when we look at the genetics, whether the mutation is clustered near the N-terminal part of the gene, because we know that if that's the case, you will not have the modifiers that you would see in skeletal muscle, and there'll be a dissociation, and the cardiac phenotype might progress very, very quickly. So it should set some alarm bells ringing, or you should be referring much earlier or for more regular follow-ups with the cardiologist. And I thought we're very briefly, I know, we're probably pushing for time and it's almost close to bedtime. So I thought we would just very quickly go through the new therapies. So basically, knowledge of the genetic etiologies has created novel opportunities for treatments. And emerging treatment targets include gene therapy, myofilament function, protein quality control, and metabolism. So this is a really nice chart, and this is quite a recent review, which I thought was very useful. So basically, new therapies under consideration fall under two main categories: approved drugs that are repurposed for new indications, and completely novel class of drugs, or non-pharmacological approaches. Obviously, we're all looking at genetic therapies where there's gene replacement, gene silencing, somatic gene editing, and these are very specifically directed to myocytes. I'm not talking about gene therapy, in the larger picture of DMDs or BMDs. I'm just talking about gene replacement, gene silencing, and somatic gene editing, which is the same sort of theory that we would use for other gene therapies for broad spectrum of conditions. And within this particular cardiomyopathy phenotype, we're also looking at modulators of primary disease pathways. So that's really important. So genetics has allowed us to understand primary disease pathways, so looking at myosin modulators or protein stabilizers or anti-aggregation aggregates or modulators of protein quality control. We're also looking at secondary remodeling, where we're looking at neurohormonal blockade, as well as metabolic conditions, specifically calcium or other signaling pathway. And of course, there's lifestyle intervention, as with everything else. And of course, when the final bit is treating the heart failure and arrhythmias, which I'm sure my colleagues would be more than happy to answer, which isn't really my domain. So I thought I'm not going to go into it. Very briefly about gene therapy and what's happening with it. So we're looking at gene replacement, where we want to rescue the function, the functional protein level. So we're just looking at replacing whatever is lost in terms of function, where you have a reduced functional protein. So you just rescue whatever is functional. Then we, are looking at other treatment modalities which allow us to help remove the abnormal function or silence the abnormal functioning protein, which is the gene silencing therapy. And finally, we look at direct genome editing, which is sort of looking at the homologous recombination and permanent repair of genes. So these would be the sort of things that we would specifically look at cardiomyopathies and gene therapy. So I thought this was a really quick one because I didn't want to take away from the cardiology aspect, but I think the most important takeaways for me, from a genetic perspective, is that very often when we are faced with a neuromuscular condition that we refer to cardiology quite early or get basic investigations done. That's really important. Once we get the genetics, I think it's really important to delineate the pathways to understand better, because that helps us prognosticate for our patients and look at changing or being very patient or tailor-made for our patients in terms of how we want to follow them up, how quickly, because they are rare disorders. We don't have a lot of natural history data on everything. So it's more a question of understanding pathways in order to predict outcomes. So looking at genetics from a more proteomics functional perspective becomes equally important in terms of how we manage our patients. So that's pretty much me done. Stop sharing.
That was very precise, and it was actually a very, very good summary of the genetics, which often people find it like Greek and Latin, people like me, but that's why even I understood what you were talking about. So that's a very nice talk. Any questions from anybody, and any comments from the floor, please? Thank you.
The one
Dr.
comment,
Kalyan,
thank
you want to
you,
add
Dr.
something?
Gauri, for that really precise, very, very comprehensive talk. And one, I'm linking your talk to your previous speaker to say that, Dr. Maniram, you had mentioned something about CFTD and having poorer prognosis. So for us, CFTD is not a diagnosis. There are so many mutations that cause CFTD. There are BINs, there are dynamins, there are so many other ones. And depending on, there are MTMs. We know that some of them have, so what Dr. Gauri said is something that we are also very wary of now. We know that some of them progress very quickly with regards to their cardiac, but only if we have the help of somebody like Dr. Gauri, and you have your wife around who's a geneticist. I'm assuming that is the way forward. So sometimes Dr. Saravanan takes care of our patients more, a bit more babies their heart if we are more concerned about them. Would you agree with that, Dr. Gauri and Dr. Saravanan and Dr. Maniram?
Ma'am,
Dr. Maniram,
I agree. I agree, ma'am. From whatever, again, we don't have very large numbers. From whatever I have seen, I think it is those homozygous variants, where both the alleles are.
It's not just the homozygous. Dr. Gauri, XLMTM, if it's not just homozygous, some of them are very severe, some of them are not so severe, no? Both cause CFTD.
Sorry, I was talking to the into vacuum. Yes, so I think the important thing here as a takeaway from genetics is genotype phenotype correlation to a large extent is becoming a consequence of proteomics, and especially in these phenotypes, the neuromuscular phenotypes with cardiac involvement. So I think it's becoming a little more challenging in terms of how we correlate just looking at the genotype. And we probably need to be looking at long read sequencing, RNA sequencing. I think that's going to be the future of cardiac things. But I think certain mutations, if there are in certain areas, especially closer to the promoter areas, whichever mutations, those ones tend to be slightly worse or progress quickly. And those are the ones that should be highlighted to the cardiology colleagues earlier rather than later. So it's quite variable, but I think just looking very clearly at the genetics and pushing or finding colleagues who are looking at eventually establishing long read sequencing or looking at doing RNA studies would be the way forward, really, in terms of prognostication with this particular subtype. And I'm not including the inherited metabolic disorders with cardiomyopathy. They tend to generally follow one particular pathway in terms of getting to the diagnosis is tough, but once we get them diagnosed, they tend to have the same sort of, or similar. The natural history is a lot more well-defined, and the genotype-phenotype correlations are better.
Dr. Gauri, as somebody who does not understand genetics as much as you do, I'm going to put that back again, simplify it a bit more, and tell Dr. Maniram and the cardiologists in the group that sometimes, correct me if I'm wrong, I'm sorry, I must be technically wrong. Sometimes a mutation may not completely disrupt the protein. And you might have some protein function retained, which means that you might not have such bad cardiomyopathy. Am I wrong in that, Dr.
No.
Gauri?
So you have the whole loss of function, gain of function.
Yeah.
All of that is not.
Yeah. So that is why, Dr. Manira, so the way so DMD, we are very pakka about what we're dealing with. And so we are doing GLS and spectral tracking for all the children. So by 5th birthday, 50% of our children are on ACE inhibitors. 10th birthday, everybody gets it as a gift, birthday gift, whether they have echo or not. And most of these people are on mineralocorticoids. As a consequence, we do have, in India, we have a national average. We have been told that the national average of life expectancy in India, we have published literature which says it's 15, whereas published literature says it is 42 in France, 39 in Britain. The center I trained in London, our patients were living till 45. I didn't answer your question about VAD because we had children that we put on VAD. So I feel very strongly about this group. So we are very aggressive in the way we manage cardiac. So by the time they hit the 10th birthday, most of our children are on 3. But if you do an echo on them, their echo numbers are all normal. But as a consequence, they're all better. And because we are starting corticosteroids so early, they're all walking till 16, 17 sometimes, if they're early on in the promoter region, or if they're in the 44 region, in the deletion indication. So much so we are questioning ourselves to say, is it DMD? Is it something else? We're disease modifying them.
I think the point that I think the point that Anne is so vociferously trying to make is that we all have to be a bit aggressive with these children because all guidelines lag behind clinical practice because of lack of evidence. And therefore we have to create the evidence. And we actually published our data very recently in the JAC Asia. And there we actually showed, it's purely looking at our clinical practice. And we did show that there were more children who were at much younger age found to be having cardiomyopathy, even at the age of 2.5, found to be having some evidence of underlying cardiomyopathy. The youngest was 2.5. So we became very aggressive about going with medication straight. Definitely ACE inhibitors. So almost every child gets ACE inhibitors, but there's nothing to lose. So that's the point I think she's trying to make. Yes, please go ahead.
With regards to prednisolone versus prednisone, is there actually some difference, ma'am? Because
everyone's moved from prednisone and prednisolone, we give deflazacort. That's the drug of choice at the moment. And people are talking about vamorolone, which is the steroid replacement. I don't know if Dr. Gauri knows more about it. We're beginning to go. It's been approved by US FDA, but it is very expensive. So now you'll get parents who come to you and say, "Doctor, can I get vamorolone?"
Yeah, but it's something that we should think about applying for, because it looks very good. The preprint looks very good. So I think something we should definitely look at seeing how we can get it here.
And also givinostat, HDAC inhibitors. Yeah.
So I think the distinction is whether we're looking at treating the disease as such, because there are two aspects, the cardiomyopathy sort of function when we're looking at whether we're treating the dilated or the restrictive in terms of gene therapy, because you're looking at end organ effects with the abnormal protein, or whether we're looking at treating the condition as such with gene therapy, which is like two distinct features. Are we looking at end organ effects, or we're looking at the treating at the main condition? So that's sort of where we are at in terms of repurposing drugs versus the gene therapy.
I'm just also adding, being a devil's advocate here, what we've noticed is that those children with better motor preservation seem to have more cardiac. I don't know if it's because, especially those with behavioral problems, if they're running around, they're stressing out their heart, they seem to have more cardiac problems. It doesn't seem to be always only neurological, only the mutation. The same mutation, if one child is a bit more active, they seem to have more cardiac affectation. Dr. Gauri, any comments on that?
So I briefly touched upon that, when I was talking about the N-terminal part of the gene, or whether it's the mid-rod domain. So the N-terminal part is more towards the promoter, muscle promoter of the dystrophin genes, because it causes, there's a deletion or frame shift in that particular area. As a consequence, you have a more significant cardiac manifestation, not as much as skeletal, because the skeletal promoters expression is not that affected, because it's affected, or rather it's modified by other promoters. So that itself, as I said, causes that dissociation, where sometimes you can, even if you don't have a significant skeletal muscle phenotype, you can have a very significant cardiac phenotype because of where the mutation is.
No, what I meant is not that. There is, because there are theories and hypotheses for that. But in our practice, like we've got like nearly 500, 600 children with it, we're not able to get a correlation. Twins with the same mutation, we see one worse than the other.
So obviously with genetics, there's a lot of modification as well. The twin studies had been tested. So that's something that we could probably look at in terms of how they have done. But these kids might be, again, how the expression of protein is in individual areas. So these might be cases we should be looking at doing RNA studies in terms of, trying to prove our hypothesis or disprove our hypothesis. But I think it's the only, apart from the hypothesis, the thing we know for sure is that the N-terminal domain, areas which, mutations which include the N-terminal domains, we know that there can be a dissociation between the cardiac and muscle phenotype. But specifically for twins, we were saying, over a period of time, and you've got a really huge cohort. So I think now is the time to really write about the natural history of disease, with the stuff. And I know you've got lots in the pipeline, but the cohort is so huge that it really merits us looking at it, because what our other colleagues might be able to glean from this information is that we just need to be aggressive from get-go. And that might be specifically how we are modifying the natural history of disease. And that's why I think that's a paper that needs to be written ASAP with your cohort.
Oh, okay. Shall we ask the moderators to say some words?
Great. Yeah.
Dr.
It all sounds great. The one last thing I wanted to ask all of you, this is about a lot of DMD children's parents, as understandably they're boys and they're precious children, and they all come and ask about gene therapy. They almost always, the last question they were before they leave is, what do you think?
Goody, I'm glad you asked this question.
So where are we? What should I tell them? I say, go and talk to Dr. Anne. She knows more about it than I do.
You need to say, so there have been deaths with gene therapy, and that is why it is licensed only between that 4 to 5 age, and the death happened. So this is like a moving story. An older brother who's a scientist, developed for his own brother a gene therapy. And that child died because he was too old. The immune-mediated stress that involved his body, his heart did not have reserves. So he went to cardiac failure. And he died. So gene therapy is not, Dr. Gauri knows more about gene therapy, about about all the, like I'm told there's more than 1,000 different gene therapies. So gene therapy in DMD is not a joke. There's nearly 10 plus gene therapies in the pipeline. Only one has been FDA approved. That is only for that smaller age group, because we know it works, but we know that they do not tolerate it when their heart is so badly involved. Dr. Gauri, would you like to comment?
My standard answer to them is, we are still not in the stage where we could roll it out for every patient or the right patient or whatever. At the moment, it is still a research tool. So am I right?
No, it's approved. It is approved. Yeah. It's 26 crores. It is approved. It's called Elvidis.
Okay.
So Elvidis was rolled out last year.
If somebody could afford that therapy, and if the child is in a very early stage of DMD, then
only then
you would.
Yeah. If they can afford the treatment, there's going to be compassionate access programs, but it will.
And could they just register for that if they were willing to afford that kind of therapy?
Yeah, we can give it. We can give it. Okay. So nearly 300 plus children have been dosed with that medicine in the US. 2 children in Dubai have been dosed. It's very soon going to come to India. So Roche is the one that's marketing it. But you have to go. So they've read all these things. They've read about Elvidis. They're coming and asking you about Elvidis. But at least if you tell them, your child has got a good lifespan, you have to tell them, the point is 15 years is in India 45 years is in the rest of the world, in developed countries. So if they come to you, you're a specialist, you're saying you're going to keep your child alive till 40, 45 years. And in that time, they will get therapy. But if you give them gene therapy, when they're not prepared, that might kill them.
So, just a very small caveat. So, as a predomminant, so my main training was inherited metabolic disorders, and we're great believers in newborn screening, because it changes outcomes, and we know how effective it is. And I think one of the conversations a lot of the Western world is having is about screening for DMD, and I think that's the conversation that sparked off in terms of how are we going to address it. So yeah, so fine, we got a newborn screening result. If we're going to screen them, we've got to have treatment. And that's the sort of basis of newborn screening in any case. And a lot of this conversation around gene therapy is becoming available. And that's where they're then looking to feed back into newborn screening. So the new gene therapy is very exciting, but obviously cost factors and the fact that it has to be an early pickup and no cardiac involvement. So those will be, there are very strict criteria for this particular gene therapy.
And they're also strict about which deletions, not all deletions.
Not all deletions. Yeah. The genetic framework is very, very important in addressing, because as I said, you're looking at whether you're looking at the silencing or whether you're looking at, introducing or, optimizing the protein function, or you're just editing the whole genome. So we're looking very clearly as to what would be the best way forward.
Excellent. On that note, on the very high note, if there are no other questions, thank you very much to Dr. Maniram and both the speakers for giving a fantastic talk on completely different perspective of the same condition, clinical as well as a very advanced genetic discussion by Dr. Gauri Krishna. I really did like both the aspects of looking at it. So bench to bedside. We need to bring those bench to bedside together more often, and I'd be delighted to be part of all of this. And I really enjoyed this evening. I hope all the attendees enjoyed as well. Thank you very much for attending, and any other comments from anyone else is welcome.
So just a thank you, a vote of thanks. Thank you to Dr. Kalyan Reddy. Thank you so much, sir, for coming in, and Dr. Saravanan for moderating the session, both of you. And thank you to ORDI, and thanks to our excellent speakers. Bye-bye.
Thank you. Good night.
Thank you.
Thank you.